right, thank you. Good to see everybody here in person and those online. I'm Doug Opel, Director of the Truman Katz Center for Pediatric Bioethics and Palliative Care, and it's really a delight to be able to introduce Dr. Jeff Robinson, our speaker for today. He's a professor and past chair of communication at Portland State University, and he's a sociologist, receiving his degree in sociology at UCLA. He studies actual doctor-patient communication and its association with outcomes of care, and specializes particularly in language and social interaction, with his analysis really rooted in the rules that guide interactions, use, and interpretation of language, as well as the role of talk in the construction and negotiation of social meanings, identities, and relationships. He's really taught me a lot about the social elements of language. He has considerable experience in identifying and coding discrete and meaningful communication behaviors and in the association of those communication behaviors with outcomes of care, particularly in the context of primary care and especially and including pediatrics. To do this work, he has videotaped over 1,000 community-based visits, and I think we'll see some of those today. I've been lucky to collaborate and learn from Dr. Robinson for over a decade, as we've jointly characterized clinician vaccine communication practices and their association with vaccine uptake. And before me, he's collaborated with many here in the room, Dr. Mangione Smith and others, on communication practices and their association with antibiotic use for respiratory illnesses. So please join me in welcoming Dr. Robinson.
Thank you, Doug, for that very generous introduction. I guess I've got a disclosure I've got to make, so there's my disclosure slide. But I think I'm just going to jump in, and before I back up a little bit, but I'm just going to jump into one case study about the types of stuff that I'm interested in. Ultimately, I'm interested in word choice and word positioning, and detailed word choice and word positioning and how that matters. So this first case study was how to deliver diagnostic news to breast cancer patients. And one of the things that I was looking at here was hopelessness, okay, as an outcome. We know that it's a critical psychosocial outcome for breast cancer patients. Women who are more hopeless with their prognostic outcome are more anxious, depressed, stressed, and they suffer a decreased quality of life. And we also know from several longitudinal studies, about 35 years now, that hopelessness is actually associated with cancer recurrence and mortality. So it's a big issue. And so what I did is I videotaped 132 treatment recommendation visits of consultations between newly diagnosed women with breast cancer and surgeons in the US. As you probably know, that's a pretty standard model, which is that once women get a diagnosis, the first provider they usually see is a surgeon within about 3 to 5 business days, not even their primary. Okay, so all of these women were about 3 days out from their diagnosis. And I measured women's levels of hopelessness immediately pre and post encounter, so I could look at changes. And then I looked to see if communication variables were associated with hope. So here's an example. All of my data is actual care that I videotaped and gotten permission to show videotapes of. So what I'm going to focus on as just one of these little communication variables that mattered was how these surgeons deliver diagnostic news. And there are roughly 2 ways that it can get delivered. I'd say the majority way that it gets delivered is without a good news frame, okay, without a good news frame, an explicit framing that this is good news. So in this case, the surgeon says, in your case, on your pathology, we actually see evidence that you have some ductal carcinoma in situ. And let me just play that.
In your case, on your pathology, we actually do see evidence that you have some ductal carcinoma in situ.
Right.
So you've got some of these ductal pipes that have cancer cells in there.
Okay.
Now, when I interviewed surgeons after, almost to a surgeon, they said, that's good news. And it is good news. It's great news, actually. But surgeons orient to that as good news. They deliver it. They would report that they gave good news. But there's no good news frame there. And now that can be contrasted with something like this. The surgeon says on the right side, you have what's called DCIS, ductal carcinoma in situ, and the patient just nods. And if you actually have a chance to notice, you'll see that the daughter over here starts to take notes in terms of, okay, we're going to get a technical explanation here. And then the surgeon says, And what that is that's not an invasive cancer, it's a precancer, and that's good news. She's about to say, and that's good news, but you'll see that the patient, oh, well, good, that's good news, isn't it? Okay, everyone orients to this as a good news frame.
On the right side, you have what is called DCIS, which is ductal carcinoma in situ. And what that is that's not an invasive cancer, but it's a precancer. And
That's good news,
that is
isn't
good
it?
news, yeah.
Okay, so it can be delivered in different ways. And then you can just see this happening throughout, right? You can either say your cancer is actually very strongly estrogen and progesterone positive, which is good news, okay, if you're suffering from breast cancer, or you can say that, and so that's actually a really good thing. Or you can say it's probably been there a long time, it's just kind of slowly grown, so it's a slowly growing tumor, that's good news. Or you can add these kinds of parameters actually tend to mean better survival, better outcome. So just adding that good news frame is one of the things that I looked at. And what we found is that good news framing, right? Good news framing is associated with women being more satisfied with their visit. We'll talk about satisfaction as an outcome later, which in turn is associated with women being less hopeless. So there's kind of an indirect relationship between diagnostic news framed as good news to patient satisfaction to decreasing patient hopelessness. That's the sort of thing that I do, that I'm interested in. And again, we'll talk about this a little bit later, but again, in interviewing these doctors, they would all say, I gave good news, even if they didn't give the good news frame. But from a patient perspective, they need that good news frame. If you don't have the good news frame, you don't get the effect on hopelessness. Okay, so I'm not going to take you back to the future, but let's just step back a little bit and let's just kind of like, where did we get here communication-wise? Like how did we get where we got to? So I just want to say a little bit about does communication matter? Really briefly, up through the 1980s, there was this question of does provider specialty matter for diagnostic outcome as the outcome, diagnostic outcome, okay? And so we know, you know, that there are practice differences between internal medicine and family practice doctors. So internal medicine uses significantly more physical exam procedures. This is still true today when it's compared to family practice. We know that internal medicine uses significantly more laboratory testing than family practice does, okay? So they're practicing differently, right? But it turns out that diagnostic outcomes are equivalent, okay? So the issue is that family practice and internal medicine doctors kind of get at things differently, but they all tend to provide a similar diagnostic outcome. And so the issue was, well, then maybe communication doesn't matter. If we're all kind of working our way differently, but we're all coming to the same diagnostic outcome, maybe communication isn't as important. And I should say that if you haven't read McDuff's Nature article on AI, I would recommend it because this focus on diagnostic outcome as the outcome is really being accentuated with AI, which we know AI assistance can actually increase diagnostic outcomes for providers. Okay, but diagnostic accuracy, of course, is not the only important outcome, right? So there are things like patients' health status, their physical health status, their mental health status, their emotional health status, super important outcomes. And there are patient satisfaction with visits, providers. Satisfaction tends to not be a very popular variable, has a high ceiling effect. It's kind of a squishy variable, but it turns out that it's a super important variable because it's related indirectly to a lot of these health outcomes, which is why it's consistently measured. And I don't know how this works here, but like in Geisinger care in Pennsylvania, physician satisfaction scores are tied into their merit increases, which is probably not a good thing, but that's how important Geisinger figures it is for health outcomes. So up through 2000 then, the issue was, okay, well then does provider specialty matter for these outcomes? Okay. And so there was a big randomized controlled trial comparing internal medicine to family practice. And what they found is that there's actually no significant specialty differences for these outcomes. No significant specialty differences, right? Really where all the differences came in were communication differences. Okay, so it didn't matter whether you were a family practice or an internal medicine doc, but if you were using particular communication strategies, you were actually affecting these outcomes in different ways. And so then it was like, oh, well, maybe diagnostic outcome is, but for these other outcomes, communication does matter or might matter, right? So by, it's about 2010, we've got a number of meta-analyses that are showing now that general types of communication are shaping a variety of health outcomes. And I say types, which is super important because these are kind of like very molar communication categories. Ask an open-ended question. And of course, my issue is always like, but how, right? But we've got these big coding typologies that are showing some promise for communication. And so, for example, we know that communication strategies do massively influence patients' adherence to treatment recommendations. It's just one example, okay? So DiMatteo has studied this. And so by 2010 or so, we've got kind of a full buy-in by the profession of medicine, kind of full buy-in to this kind of patient-centered model of care, which I don't need to talk to you guys about. And we've got a sort of a robust typology of patient-centered communication strategies. Okay. So, for example, we know that there are a variety, that communication strategies that generally promote patient involvement in care are good, okay? Again, these are typologies. These are like gross communication categories. Oops. So things like, we know that when you solicit patients' concerns or preferences to their fullest, you tend to increase adherence to treatment recommendations. We know that when you ask patients if they have questions or additional questions and concerns, that can promote treatment recommendations. But we still haven't answered, or we haven't addressed the issue of, does it matter how you ask those things? Right? Does it matter how you do that? And I've been doing this for a long time, and when I do CME trainings, 15 years ago, I would give providers these general typologies, and there was always questions of like, but does the wording matter? How does it matter? Okay, so by 2010 then, the problem here is that there's also mounting evidence that these typologies, these general typologies, are not sufficient. Okay, they're not helping doctors be better doctors. And that's because, and so we know, for example, there's a bunch of meta-analytic evidence out there. We know from experiments, that's going to be important, right? Because these are very ecologically invalid things. But we know from experiments that the exact same type of communication, the exact same general typology of communication operates differently with very slight formatting changes, okay? So, for example, recommendations of behavior change, if you're trying to recommending behavior change for a patient, smoking, drinking, weight, we know that they're significantly more effective when you emphasize the social consequences than when you emphasize the physical consequences. Okay? So, for example, in one experiment, if you stop smoking, you'll be able to spend more time with your grandchildren, is significantly more effective than if you stop smoking, you'll live longer. Now, we haven't tested this out in the vaccine space, but this is really interesting for me in the vaccine space because, if you're trying to get a mother to vaccinate her children, is it better to say, if you don't vaccinate your kid, they'll die of a horrible disease? Or if you vaccinate your kid, they're going to miss less school and you're going to miss less work. So, these sorts of things have massive implications for treatment. We also know that informing patients about drug risks are significantly more effective when you use numerical terms versus verbal terms. So some of you are probably aware that at least in the EU, there's kind of this equivalency between verbal term and numerical term. So, very common, common, uncommon, rare. Here's the frequency intervals. If you've got a drug that has a side effect less than 1 in 1,000, less than 1 in 10,000, there's kind of an equivalent verbal term that you can use. And in this patient-centered model of medicine, there's kind of been a big shift over to actually using verbal descriptions rather than numerical descriptions. But it turns out that verbal versus numeric terms actually result in patients overestimating drug risk. And numeric versus verbal terms result in an increased likelihood that patients actually will adopt a drug. So again, how you're framing it, are you using very common or less than 1 in 10,000 matters for patient behavior. Okay, so then the question is, the question is not, does communication matter? But really the question is, how does communication matter? How does it matter? And so to date, the majority of research on wording choice, specific wording choice, suffers, I think, from problems of validity and or reliability. My work, Doug's work, a lot of the work that I did with Rita Mangione-Smith are trying to address this issue by looking at actual care, but it still really exists out there. So for example, obviously social psychological experiments, they suffer from a lack of external validity or ecological validity. How do you actually translate those experiments into real life practice? And that translation often gets lost due to a variety of clinical hurdles. And so most studies of actual communication also, they tend to measure wording choice by having providers and patients self-report what they did and what they said. Obviously, that's much easier to do. It's much less expensive to do. But there are real serious problems with self-report. I mean, real serious problems with self-report. Self-report of even the grossest communication behavior is notoriously unreliable. So the majority of the work that we have out there about what we think doctors and patients are actually doing and saying, it's very difficult for me to buy into them. So I actually did a study where I set out to seriously compare this. Like, I videotaped visits, I compared chart records to self-report by doctors and patients about communication to what actually happened during the visit, okay? And I was asking questions like, I was asking patients, for example, to report, did the provider say to get more exercise? Like gross things like that. Did the provider say to stop smoking? Did the provider solicit your opinion? Did you ask about treatment? All of these things not correlated at all with what actually happened during the visit. That's scary. That's scary. And then, providers are not much better. I'm working on a study with Doug now where, we asked providers afterwards to, did you give patient treatment options? And almost to a T, they'll say, yes, I gave patients multiple treatment options. No, they did not, right? So I recommend that you do X. Okay, end of visit. But the issue there is, again, it's like with the surgeons. It's not, the providers believed that they gave options. And so the real issue is, what is it about the communication environment that led them to believe that they gave options? Just like the surgeons believed that they were giving good news. There's a lot of subconscious things going on that providers are not really aware of. So I'm not slamming the providers. I'm just saying that the relationship between what people say they said and what they actually said doesn't really work. Okay, so, I think I'm going okay. I didn't even pause to say, like, am I comprehensible? Joe up there, like, is the audio working? Okay. I feel like I'm going a little bit fast, but I want to take you through 4 more case studies then with this frame in mind, no pun intended, that communication matters. Okay, so the first case study then is, how do you solicit patients' chief complaints? Does wording matter? Okay. And we know that very subtle shifts in your question format shape outcomes. And so there are probably about, I've videotaped thousands of visits, and I think of all those thousands, there's probably about 5 ways that providers begin their visit. Probably the most frequent way, but not, maybe 55% of the time, doctors will begin with what I call kind of an open-ended solicitation, which is good, which is good. But that leaves another 45% of care that starts some different way, okay? I'm just going to go through two of these strategies. So the first one is open-ended solicitations, things like, what can I do for you today? This goes by very fast.
What can I do for you today? Well, I feel like there's something wrong down underneath here in my rib area.
Okay, and that seems like nothing else is like, makes common sense, right? Other examples of open-ended solicitations would be things like, how can I help? What's the problem? What's going on? What's the trouble? Tell me about your problems, okay? Now, these types of formats have two features which are going to contrast with the second one that I'm going to look at that distinguish it from the second one. Okay, the first feature is that linguistically, these are designed to communicate that the provider does not know about the problem. And I hope that you can immediately see why doctors resist asking these questions. Is because doctors, at least nominally, are supposed to have read the records before they go in. I've done a whole study of that. It turns out that doesn't happen very often. But doctors don't like to be perceived, and there's a very common norm, social norm in our society, that you don't ask people for information that you already know, right? If I start asking you questions for things that you think that I already know, you're not going to hear that as a question. You're going to hear that as what else are you up to, right? So doctors don't like to ask these questions because they feel like patients will think like, well, you should know, right? So they're designed to communicate a lack, but what that does communicationally, right, is it actually incentivizes patients to fill in the details, right? If I figure that you don't know my problem, then I'm going to tell you more about my problem. If I figure that you know my problem already, I'm just going to give you a one-word answer and I'm not going to go anymore. So that's the first feature of these questions. And the second feature is a little bit more complex, but it has to do with the structure of interaction, the structure of turn-taking. And that is that as an action, what it requires patients to do as the first order of business, the first thing they're supposed to do is to present their problems. And you may say to yourself, well, but what else would you do? But kind of think about it this way. If I ask you a when question, you've got to give me a time. If I ask you a yes-no question, you've got to give me a yes-no, right? If I ask you a where question, you've got to give me a location. This question basically says the only thing you need to do and the first thing you need to do is just start presenting your problems. And that's what this patient does.
What can I do for you today? Well, I feel like there's something wrong down underneath here in my rib area.
Okay, now when providers begin, patients present for about 27 seconds. Now you may say that's not very much time, but you might also know that the average amount of problem presentation time since the 1980s has been about 21 seconds. So we're like beating the average here, okay? And they tend to present more than one discrete symptom. Now when you compare that though with the other most common format, which is a request for confirmation of concerns. And again, providers will report that this is open-ended. Okay, so things like, sounds like you're uncomfortable. Doctors will say, that's open-ended. I'm giving the patient the floor to present their problems, right? I'm not saying, I'm not launching into history taking.
Sounds like you're uncomfortable.
Yeah, my ear and one side of my throat hurts.
Okay, but other examples of this are things like, so you're sick today? Again, that sounds open-ended. I understand you're having some sinus problems, you're having knee problems since June. Providers tend to favor these questions because they tend to communicate that you know something about the problem, right? And you can see providers trying to communicate that I know something about your problems, but trying to be open-ended as much as possible, right? Okay, so these questions, in contrast, are designed to communicate that the provider does know, right? Sounds like you're uncomfortable as he looks at the records and the patient can see that he's looking at the records. He's showing, I know something about your problem because I've read your records, right? And the second thing, which is the more technical observation, is that as an action, it actually requires patients to do something first before they present their problems. And it's not something we think about usually, but that is requests for confirmation demand confirmation first. The first thing they're supposed to do is say yes or no, and then maybe present their problems. But the problem is that according to the structure of turn taking, normally you get a turn, I get a turn, you get a turn, I get a turn, and we normally only get 1 unit of talk before it's someone else's turn. So I'm going to show you an example of what usually happens, which is that doctors sometimes begin, it sounds like you're uncomfortable, patients say yeah, and then the doctor just takes over and launches right into history taking. And the patient doesn't get any presentation at all, okay? So notice here, sounds like you're uncomfortable, 2 things happen. First, she says, yeah. And then she says, my ear and one side of my throat hurts.
Sounds like you're uncomfortable.
Yeah, my ear and one side of my throat hurts.
Now, it's all produced together, and you might say, well, what's the big deal? Well, the big deal is visits like this, right? That after patients confirm, in many cases, providers will come in and take over and just begin history taking. So you're having knee problems since June. Yes, says the patient. Okay, what have you done for that since then? And now we're on to taking the history.
You're having knee problems since June.
Yes.
Okay, what have you done for that since then?
Okay. And strategy 2, when compared to strategy 1, patients get about 12 seconds to present their problems. And they tend to produce less than or equal to 1 symptom. And adjusting for all sorts of variables like patient's age, sex, race, education, practice setting, problem type, it turns out that requests for confirmation compared to the open-ended ones result in significantly shorter problem presentations that also have significantly fewer symptoms. And you might say, but Jeff, you told us at the very beginning that they're going to get there, right? So maybe even if they take over, they're still going to ask the right questions. They're still going to get to the same diagnostic outcome. But it actually turns out that complete problem presentations are associated with diagnostic accuracy. So getting someone to present a complete versus an incomplete presentation actually matters for your diagnosis. And it is also the case that these questions shape satisfaction. And when I say these questions, I mean just this question wording difference. So we've compared hundreds and hundreds of visits, just whether or not doctors begin one way or another way. And what you find is there's kind of this cascade of results. And so when compared to providers who use request for confirmation openings, providers that use these open-ended solicitations are rated by patients at the end of visits, right afterwards, as being significantly better listeners and kind of having a more warm, relational, affective style. So 1 question wording difference is shaping a satisfaction outcome at the end of the visit. Okay, this is some stuff I'm sure you've seen with some work I've done with Doug Opel, how to get parents to vaccinate their children. So we discovered that there are 2 basic strategies here, okay, and they kind of counterintuitively tend to run against this patient-centered model of medicine. So the first type of initiation is utterances that linguistically presuppose acceptance. Okay, things like, we have to do some shots. Okay. We'll do 3 shots in the drink. Is that okay? Yes. So for vaccines, he gets the ones that he got at 2 months. Okay. So, you're not lying at all, but you're simply presuming that patients will vaccinate. This is very similar to if you ask someone out on a date, you can say, when are we going out? And they might say, well, wait a second, we never even agreed to go out. Yeah, you're asking me for the time. But it's much more, you're going to get much more results that way than if you say, I don't suppose it's possible that you would at all want to go out with me if you have time. Like, there are ways that you can design those things to linguistically pressure people toward yes or toward no. And so here's an example of the presumptive format, and I should note that this is with a vaccine hesitant parent. So we've measured vaccine hesitancy. So the idea here is that a lot of providers will say, oh, but this would never work on vaccine hesitant parents. It actually does.
So for vaccines, he gets the ones that he got at 2 months plus the flu shot.
Okay.
And that's about how that runs off, right? Patient accepts all vaccines. compared to, oh, sorry, I just should say that compared to what you might call a participatory initiation, okay? This would be straight if you use the patient-centered model of medicine as a playbook for how to design these things. You would actually tell providers to use a participatory style. And these are utterances that linguistically provide parents with latitude to make the decisions themselves, which is patient-centered medicine, right? So things like, are we going to do shots today? Or what do you want to do about shots? Or even, worst of all, you're still declining shots, or I guess you don't want to vaccinate because you didn't vaccinate last time. Now, here's an example. The provider is kind of tucked back here behind his computer of a participatory format. Any thoughts you guys had on the normal one-year shots, which you may or may not want to do? And the mom is going to just choose one of about 3 that her child is eligible for.
So, any thoughts you guys had on the normal one-year shots in which you may or may not want to do?
I think I just want to do the pneumococcal.
Okay, so I think I just want to do the pneumococcal. The patient actually resists full vaccination. So compared to participatory formats, presumptive formats resulted in children receiving significantly more vaccines by the ends of visits and in being significantly less under-immunized over time, okay, over time. We also found that although during a first visit where a presumptive approach gets used, there might be a slight decline in satisfaction, okay, where parents are kind of like, it's kind of like, when are we going out? Like the person might say, well, wait a second, that was kind of a rude way of asking me, right? But ultimately, over time, these things even out, okay? And so, okay, so presumptive formats, and that's counterintuitive, right? It's counterintuitive relative to what we know about the patient-centered model of medicine. The issue is what do you want your outcome to be, right? Case study 4, how to solicit patients' full agenda of concern. So we've already talked about opening the visit and soliciting the chief complaint. But as you probably know, 58%, I think it's now, 58% of primary care patients come in with more than one concern. And so the issue, and we know that the chief complaint tends to only solicit one concern. And so that leaves this issue of unmet concerns out there, right? So patients are often leaving visits with unmet concerns, which can complicate health conditions, certainly are costly for healthcare systems. That's a larger conversation about how we deal with that. Do you get them to make another visit, listing? But bottom line is unmet concerns are not great for health outcomes and for financial costs. Now, the most optimal way, and the way that probably most clinicians were trained, at least according to I think about 6 of the 8 textbooks that are out there, to solicit the full agenda of concerns is to solicit the chief concern, and then the patient tells you, and then you nod or whatever you do, and then you're supposed to ask, do you have any other concerns? That's the place where you're supposed to ask that question, right? So things like, patient completes the chief complaint, and the doctor says, yeah, we can definitely push you in to see ortho. Okay, that's no problem, all right. How are you otherwise? Any other concerns? And in this case, the patient says, I'm doing fine, but I had a reaction to the flu shot, and I have a sore throat, and new concerns come out, okay? But this never happens. Okay, so in a study of about 500 primary care visits, it happened about 5% of the time. Where it usually happens is that classic doorknob handle question. You're about to leave, you ask. It turns out that when you ask this question at the end of the visit, patients perceive that as not a genuine question because you're already effectively out the door. You don't literally have to have your hand on the doorknob. If you ask it at the end of the visit, it's significantly less effective than if you ask it after the chief complaint has been provided. Now, the wording of providers' questions actually matters in a super, super subtle way. So if you're trying to get people to solicit additional concerns, there are at least 2 different ways that you can ask this question. And most of the time in actual care, doctors are using any, the word any, all right? Is there anything else you would like to address in the visit today? Now, any is, in linguistics, what we call a negative polarity item. It tends to presuppose a no answer. So at the end of this talk, if I say, do you have any other questions? You will hear me as saying, please, dear God, do not ask any questions, okay? But if I say, what are your questions, or do you have some questions, you'll hear that as, oh, he's open to hearing questions, right? That's all encoded. All of that is encoded in this little word, any. And you can compare that to the word some, which in linguistics is a positive polarity device. It builds in a preference for a yes answer. It actually pushes people, pressures people for a yes answer. The question I had was that, would it actually make a difference if doctors asked an any question versus a some question? Would one word in one question make a difference? And so we did an RCT where we trained providers to solicit additional concerns. We had 20 family practice docs seeing patients with acute problems, 10 from LA, 10 from Pennsylvania. So we had kind of this urban-rural division. So we had 20 providers, and all providers saw 11 patients. Okay. Patients filled out a pre-visit questionnaire because we had to be able to figure out what concerns they were coming in to the visit with, right? So here's an actual sheet of one of our questionnaires, MC 1407. And this woman has filled out the answer to, please list and describe your primary reason for visiting the doctor today, and she's put lower back pain. And then in addition to your primary reason, what other issues, problems, or concerns do you want to talk about? And she's written in fatigue and constipation. Okay, so she's got 3 concerns, at least that we can document: back pain, fatigue, and constipation. And so she's eligible for having extra concerns. Of course, some people only came in with 1 concern, and they're not eligible for additional concerns because they only have 1 concern. Okay, so the first 4 patients were control patients. We just told the providers we're interested in communication. We didn't tell them at all what we were interested in. We had permission to do that. And so they're just normal care. And then after the 4th patient, we had a 5-minute DVD back then. We had a 5-minute DVD, which, actually right now, many computers still actually accept DVDs. So a 5-minute video where we trained them to ask the any versus some. It was literally like a 4-minute and 50-second video they could watch during their lunch or in their office. It trained them to ask the some versus the any with a little bit of conceptual background and some modeling. And then they went through and they practiced for the last 7 patients using either the any format or the some format. And then we also had these little sticky notes that we made where we put on the inside of their charts so that they could see them but their patients couldn't. And it actually had the exact wording, right? Are there any other issues you'd like to discuss? Are there some issues you'd like to discuss? I still get requests for these sticky note pads, so if you're interested. And as you might imagine, the any condition was easy to train. It was very easy for doctors to say, do you have anything else you want? Do you have any other concerns? The some condition was trickier, and we did have some cases where doctors would be like, do you have anything? Some, And so we had to, we had to deal with retaping and getting enough data and controlling for that. But here's a patient with additional concerns who gets the any question. She doesn't raise anything.
What brought you in here today?
I'm sick, and I've been sick for like a week. Over a week probably.
Oh yeah?
And I just have like the cough. Like it started like a really dry cough. My nose is kind of stuffed up and my ears hurt really bad, like right here and stuff. That's about it.
Is there anything else that you wanted to talk to me about today?
No, that's it.
Okay.
Okay. So the patient declines to present additional concerns compared to the some format.
Are there some other issues you'd like to discuss?
I do have some family history things that I wanted to discuss with you too.
Okay.
Okay. And the patient presents a new concern. And so really what we found is that compared to standard practice, the sum intervention was almost 7 times more likely to generate an additional concern. The sum was significantly, it was successful. The any concern, although it was increasing the likelihood of concern, so simply asking a question gives the opportunity, it did not significantly increase the likelihood compared to standard practice of generating additional concerns. So one word. And I should also say that compared to the any condition, the sum condition did not increase visit length. Providers were freaked out about this. In fact, it reduced the length of the visit, interestingly enough, not significantly, but it reduced it. I think it was by several seconds, probably because it allows the providers to better organize their visit. And none of them generated what we kind of measured as irrelevant concerns. So we were also interested in, like, the providers were like, if you do this, it's going to open Pandora's box, and I'm going to be here all day, and this is going to be terrible, and they're coming out of their offices telling me like that. But it turns out we're measuring this, and it turns out that relative to what they wrote down on their script, there was no significant increase in raising other random concerns. So it didn't actually open Pandora's box. Didn't increase visit length, didn't open the box. Okay, and finally, I think do I have 5 minutes? Okay. Okay, well, we've got some questions we got to.
What else do you want to say?
So the final case study was some work that I did with Rita and Boots and other, which was how to decrease prescription of antibiotics. And the context here is pediatricians seeing children for ARTIs. Okay, so we're just looking at pediatricians, children ARTIs. And the issue was when doctors are making treatment recommendations of no antibiotics, which, well, should be more frequent than it is, but what happens? And is there a way to shape that communication-wise? So we know that when the providers present the diagnosis, the next thing they do is they move from diagnosis to treatment. That's pretty standard, right? And we know that if the provider offers antibiotics, then that usually gets accepted and the treatment and the visit closes. And it's also possible maybe that they recommend no antibiotics and the patient is okay with that, but that happens far less often, okay? Usually what happens is they recommend no antibiotics and the parent resists, okay? The parent resists by saying something like, but what am I going to tell grandma? But it worked on me last time. Are you sure? What about antibiotics? Why won't that? There's some question or pushback by the parent. And in Rita's work, we know that when parents resist like that, when you make a recommendation and they don't accept, they resist in some way, that providers are significantly more likely to perceive parents as expecting antibiotics. So, this parent really wants antibiotics. And when providers perceive parents as wanting the antibiotics, providers cave, okay? And this expectation is significantly associated with actually prescribing ABX. So a significant amount of the variance in overprescription and illegitimate prescription is actually a communication phenomenon. It's not that the providers are not doing what they should be doing up to the point where they recommend no antibiotics. It's just that then the parents resist and the provider is like, okay, fine, okay? So in actual practice, it turns out there's about 3 ways that providers give treatment recommendations. And again, this is all from formative observational research, videotaping hundreds of visits, and just looking at how do providers actually, in uncontrolled environments, give treatment recommendations. And so here's the 3 ways. This is like 3 little pigs. Okay, so the first one is a positive treatment recommendation, which is the only thing that the provider says is what will work, over-the-counter recommendations. Okay, so that informs the patient of treatments that will work. So antibiotics are not mentioned, providers never say, I'm not going to give you antibiotics. What they say is you have whatever the diagnosis is, and then they say, so what I can do is give her cough medicine that has a little bit of a combination of decongestant and also clearing up the nose, dry it up a little bit at night so she can sleep better. Okay, says the dad. Mom's going to be like, what? So that's positive treatment recommendation only is one way. But that tends to result in resistance. Things like, what about antibiotics? You haven't mentioned antibiotics. So the common question is, what about antibiotics? Or do you think antibiotics would work? Or I had antibiotics last time, or the last time I was here, it's always antibiotics. The second way is a negative treatment recommendation, and this is the only thing that the provider does is say, antibiotics won't help. Okay, so things like, but in the meantime, no antibiotics or anything yet, okay? Yeah. So just informing the patient of treatments that won't work, in this case, antibiotics. And this definitely results in resistance. Now, resistance can be very subtle, and probably some of you know this in your gut as clinicians, right? Which is that sometimes you give this treatment recommendation, diagnosis X, and by the way, antibiotics are not going to help, and the mom is just silent. Okay, and this has to do with the structure of conversation. Again, silence is understood as resistance because the norm is a response. If you don't believe me, the next time you ask someone out, again, and they pause for 0.5 of a second, you know that they're going to say no about 80% of the time without saying anything. And then if they begin with well, you're like, okay, it's over. And they haven't even said no yet, right? So the structure of conversation allows silence or or those sorts of things, but also things like, why not? They worked for me, but he's just so sick, those sorts of things. Okay, and then the third part is a two-part recommendation. Okay, a two-part recommendation. And this is where providers move from negative to positive. Now, they can also move from positive to negative. It turns out the best way is to move from a negative treatment recommendation to a positive, to deliver both in tandem, okay? So, which is good. That means she doesn't need antibiotics because this is probably caused by a virus. And you may know antibiotics don't kill viruses. And this is a lot of the kids is pretty common. Get to the antibiotics, right? So treatment will be, right, medicine that are going to make her feel comfortable, treat her symptoms. You can get her medicine that's going to make her nose less stuffy, make it less runny, medicine for the cough. There are a lot of theoretical reasons why this works better. You end with the agentive recommendation, something that parents can do. They feel like they can take something away. The negative is more likely to be risted than the positive. So if you put the negative first and the positive second, there's less likely to resist because the negative is sequentially detached from the positive. So we trained doctors, and we did an RCT in 8 states, 20 practices, about 70,000 patients. And we trained doctors through education. Communication training was part of it, but there was also education, prescribing feedback reports over time. And a central part of this information was training providers to deliver this 2-part recommendation. And it actually took a while to train doctors to do this because, remember with the, so you're not feeling well today, no, and then moving right into history taking, right? You usually only get one little thing to say before someone else comes in. If you're going to do a 2-part recommendation, you've got to do things like, okay, so we've got good news and we've got bad news, or on the one hand, on the other hand, right? Okay, so here's a little bit of the practice video. It's much more polished now, that we use to train the providers.
Well, he is congested, but the important thing is that his lungs sound fine and his ears look good.
Training video.
His throat is a little bit red, but it's nothing to be concerned about. So it looks like he has a yucky cold. On the one hand, there's no medicine that'll make it go away. Having yellow-green mucus doesn't mean he has a bacterial infection, so antibiotics won't help. On the other hand, there are a bunch of things you can do to make him feel better.
Okay.
First thing is lots of fluids and lots of rest. Raising his head at night can help drain some of his congestion, so you might give him another pillow. You can also run a humidifier in his bedroom at night, which can help loosen the congestion. And a teaspoon of honey can help his cough.
All right.
Okay. So, and we did a variety, several booster trainings to get the doctors to do this. Now, our interventions significantly reduced overall prescribing for ARTIs. And this remains significant 2 months after completion of intervention. So we affected ARTI prescription by about 7%, which was great. It also reduced inappropriate prescribing as well. So in conclusion then, very short, extremely small and subtle changes in communication, like a single word, can matter for health outcomes. And these changes are often not on clinicians' perceptual radar. And in fact, clinicians tend to believe that they are doing a certain communication outcome when in fact the format doesn't lead there. So again, doctors and patients don't tend to consciously attend to these differences. They're not accurately self-reported at all, okay? Even in some of the work, if I like put the spotlight on myself, right? Even in some of the work that I've done with Rita, trying to design questionnaires to measure these things, because obviously if you're looking at 70,000 patients, you can't record 70,000 visits, and this is a problem for me, of course. But even then, sensitivity and specificity on some items can be like 60%, and that's not good. Even 70%, which might be acceptable in a larger clinical trial, just still means that about a 30% of error, okay? It's just hard to get to this by self-report. And so finally, subtle communication strategies, they can be trained and they can be effective. Thank you very much.
Hi, Jeff. Thanks. This was great. I have a question about your choice of the any or some. So both of those are sort of close-ended questions as compared to an open-ended, like what other concerns do you have today? So I would love to hear more like why that's the choice that you all made.
We definitely could have done what other concerns. That would also be a positively polarized format, and that would have worked fine. And I would have imagined that would have resulted in the same thing. We were just trying to find two conditions where we could compare equally with just one wording shift to control for that. But what other concerns would have worked okay? I will say along those lines though that subtle deviations can matter as well. So in my work with Doug, you can get things like, so Johnny's due for 2 shots today. Is that okay? Providers will tag on that last little participatory kind of frame, and immediately patients would be like, well, sticking to a particular format matters, but I think your version would have worked fine.
Thanks, Jeff. What a wonderful body of work that you've accomplished. Thinking about virtual reality and just the feasibility of doing these types of studies, have you thought about incorporating virtual reality or even AI into this work to both train our physicians? I feel like 12 years later, we're still doing family-centered rounds is the way, and also to measure outcomes.
Yeah, I have not. In the work that I've done, I have not. But I am in discussion with OCHIN, which is the Rural Health Organization in Oregon, to try to see if we can't work with their medical records people to start getting some AI-assisted question prompts. Obviously, this is a huge burden on the system, who may or may not want to commit to doing this when it requires a lot of back-end work. But I think it's an excellent, excellent possibility, and probably the wave, I think, of the future.
Thank you, Jeff. The heuristics we use and sort of the biases that are in our communication are often intrinsic to just who we are and how we communicate, and we're subconscious, right? And I appreciate your last point there, that some of those can be trained and we can make insightful and aware, but it seems like there are some that really are just really difficult for us to be aware of. And what suggestions do you have to sort of improve that awareness?
Yeah, that's a big problem. I mean, I'm a sociologist, and so a fundamental principle of human communication, and this is a universal. This isn't a American or a French or a Ukrainian thing. Like, a fundamental principle of communication is to reduce conflict. So our communication norms and rules are designed to reduce conflict between people, even though there are wars and stuff. It's an evolutionary trait that we've got. We're a cooperative species, and so everything in our gut doesn't want to put people in a bind. put people on the spot, force people to make a decision. So we're really, this type of training really does run up against that, wanting to let people off the hook all the time. So I would say that the way that we've gotten around that is just training has to be more than a 5-minute video. It's usually a booster type thing. I don't know exactly how we can get around it completely. I know that from the SUM-ANY study, it was just hard to get doctors to overcome that any format. Like SUM was just really, really foreign to them. It may have never come out of their mouth ever, So I don't know what the solution is to that, although I do know from the Mangione-Smith that, over a certain number of patients, and then in our work, if you can get providers to begin even 60, 70% of their visits with presumptive formats, over time, you're still going to get a shift in behavior.
Really enjoyed this presentation. Thank you. I am curious. I'm an operations manager, so I'm wondering if your training is accessible and available if we wanted to present it to our providers as an option.
I mean, I haven't actually put together like commercially produced trainings. I do personally do a lot of CME training where I go various places and give talks and to do that, but I don't have I'm a faculty member. Where do I have the funds to do a production like that? But it's a great question. So I've got little modules that would all be perfect for that. They're just not in sort of polished formats that I could just sort of send you. But I'm happy to work with you and talk with you about trying to make something like that happen if you were interested. Absolutely.
Perfect timing, too. Thanks, everyone. Thank you so much, Dr. Robinson. This is fascinating. And we'll see everybody next week.